Tuesday, so I'm going to go over our non-stress test again. So I was kind of trying to speed up to get through it. So on your slide it says non-stress test. So the non-stress test is one of the most common methods of antenatal screening, and it involves the use of the EFM for approximately 20 minutes, and is based on the premise that a normal fetus moves at various intervals, and that the CNS and the myocardium responds to movement. So the heart rate goes up with movement, right? They usually start these around 32 to 34 weeks. And it's based on the knowledge that a well-oxygenated fetus has adequate movement and heartbeat variability. So, the woman comes into labor and delivery, they put them on the monitor. They may have like gestational diabetes or hypertension or a thyroid, disease, something that can affect the pregnancy and the wellness of the fetus. So they monitor these patients more closely. So they'll come in and they'll put them on the monitor. And a non-stress test is reactive. Let me show my slides here. So a non-stress test is reactive if there's 2 accelerations of the fetal heart rate of 15 beats above the baseline. So whatever the baseline's running, you want it to see 2 accelerations of 15 beats above times 15 seconds. And we want to see 2 of those in a 20-minute time frame. Non-reactive is less than 2 accelerations over 40 minutes. Sometimes, if you give your mom something to drink, some ice water, juice or something, it can kind of wake the baby up a little bit if the heart rate's kind of decreased variability and the baby's sleeping, because babies do sleep in utero. So their heart rate, if they're sleeping, their heart rate's not going to be as reactive, right? So sometimes you got to wake them up a little bit. And as I said, sometimes hypertension, diabetes, if they've had a previous stillbirth, lupus, different things that affect pregnancy, they'll have them come in like weekly for non-stress tests. The doctor will order them to come in. And there's a box on page 189. So if they're non-reactive, that requires further testing. And there's an example of a strip. So then the next thing is a fetal biophysical profile. And it assesses 5 different variables. And they use ultrasound. It assesses body movement, tone, amniotic fluid volume, breathing movements, and incorporates the non-stress test into that. And the variables are scored in increments of 2. I've got page 196 here. And there's a picture of the components. 10 is considered perfect, and the fetus is considered healthy. 8 is also okay. 6 would warrant further testing or repeat testing maybe the next day. Lower than 6 usually is bad. They'll usually deliver if it's lower than 6. The next diagnostic lab is chorionic villus sampling, or CVS. This is page 183, 184. This can be done around 10 to 12 weeks. It's an invasive procedure where a small portion of tissue from fetal portion of the placenta is removed, and it can reflect the genetic makeup of the fetus. Its advantage is it can be done early in pregnancy. So, if people want to make decisions about termination or continuation of the pregnancy, but doesn't diagnose neural tube defects. Some risks are spontaneous abortion, infection, hematoma, and even intrauterine death. And there's a picture of that. They use ultrasound guided so they can tell where they're going in, of course.
What does that test for?
doesn't test for neuro two. It could probably tell you like, when we're talking about genetics, it could probably tell you like Down, something like that. But it doesn't test for like the spina bifida or the anencephaly, anything that's a neuro two defect. And we have our amniocentesis. That can be performed after week 12. Remember, if they're invasive procedures, they require a patient, signs consent. That's part of our job, is to get their consent. Frequently performed late in pregnancy to provide information on fetal lung maturity. This is another prenatal diagnosis of genetic disorders. It can tell us congenital anomalies such as a neurotube defect, spina bifida, anencephaly. It can detect pulmonary maturity at 30 to 35 weeks. So we can determine if we need to deliver our patient earlier, or is the fetal lungs mature, because that's what we worry about. We can have a big baby, but are their lungs mature? Like with our gestational diabetes, the babies are going to be bigger, but are their lungs mature? Are they ready to be outside of the womb and use those lungs to breathe? So they would sometimes check the pulmonary maturity before they made that decision, if the mom's stable. So you assist the physician during the amniocentesis, you obtain baseline fetal heart rate and maternal vital signs. After the procedure, you're going to review any reportable side effects with the mom. You're going to assess vital signs and fetal heart rate again after. So monitor fetal heart tones for 30 minutes before and after procedure. And that's a picture of that. And your takeaways are your documentation, crucial document accurate information at every prenatal visit. And we don't want to forget our psychosocial and emotional status of the mother and significant others. Any red flags and behaviors. And that's all for safety and security. Electrolyte, we're going to go through a little fast because there's not a whole lot of information. I'm going to hit the high spots here and get to some other stuff. So it's our responsibility to provide education and counseling concerning dietary intake, weight management, and potentially harmful nutritional practices for pregnant women. So nutritional history should be obtained on all pregnant clients regarding their eating patterns, changes in appetite, any difficulty chewing or swallowing, taste, presence of vomiting, diarrhea, constipation, all those things that affect our eating, any food allergies and intolerances. So chapter 8, page 154, 8-1. So weight gain does not equal adequate nutrition. Normal weight gain is about 25 to 35 pounds for females with normal BMI. Twins, we say 37 to 54. Often pregnant women are told to eat as much as they want because they're eating for two. However, this is not necessarily accurate. So, for those women who are overweight or gain too much weight during pregnancy, it increases their risk of gestational diabetes, which can cause the larger infants, puts the infant at risk. Can cause hypertension, preeclampsia, increased risk for C-section, thrombosis, postpartum hemorrhage, and obese children. So our pattern of weight gain is usually 1.1 to 4.4 pounds total in the first trimester, and then an average gain of 1 pound per week during the last 2 trimesters. Remember, we get a weight on our clients at every prenatal visit, so we can keep track of that. Page 157, 159, table 8.2 and 8.3. In your first trimester, they recommend you increase your calories by about 340 or so, give or take. And your second and third by about 450. course, protein's necessary for tissue growth and repair. It's also necessary for your fetal growth. And you can look, if you have a nutrition book, you can look up this information in there as well. Your calories can be increased by adding 2 milk servings of 1 meat or protein, so like an extra sandwich or fruit or milk. And I also found it interesting that the book states that approximately 75,000 additional calories overall is needed during pregnancy. So that's about 2,200 to 2,900 per day, depending on your activity level, your age, your BMI, things like that. So, of course, protein's found in meat, poultry, eggs, fish. Of course, we want to watch our mercury. Some of our fish have mercury, so we want to watch that. That's dangerous. Dairy products, milk, cheese, yogurt. If they're lactose intolerant, we can do soy milk or soy cheese, things like that. Of course, beans and legumes. Protein's important for growth of maternal tissue. You know, we talked about how the tissues in the breast and the uterus and everything expand, so we need that protein to help with that, plus our fetal tissue and organs. Fats are eaten in moderation. They're needed to absorb fat-soluble vitamins like omega-3. And if fats are eliminated, the body starts burning protein for energy and depletes their protein storages. So we need some fats. Iron is important due to increased blood and circulation and increased risk of anemia due to depletion. Of course, iron's in red meats, organ meats, fortified cereals, dark green leafies, and beans. Iodine is needed for thyroid function, and magnesium helps with cell growth and neuromuscular function and the metabolism of protein. So table 8-3 has your vitamins. So your water-soluble vitamin B and C. We want to avoid the bone meal supplements. You know, some people take bone meal supplements. They are sometimes contaminated with lead, so we need to avoid that. We need to avoid pomegranates. They're rich in vitamin C, magnesium, potassium, and folate, but they have a potent stimulant that can cause uterine contractions. They're unsafe during pregnancy. So specifically, the daily intake of calcium, iron, folic acid must be adequate to meet maternal fetal needs for adequate growth and development. Vitamin C enhances the absorption of iron. And they can find that in like red and green sweet peppers, oranges, kiwi, strawberries, grapefruit. Folate or folic acid is important for the prevention of those neural tube defects, the spina bifida and the anencephaly. Remember to teach to thoroughly cook eggs, meat, seafood, and they want to avoid unpasteurized dairy because toxoplasmosis and salmonella. Listeria they can get from hot dogs and lunch meats unless heated until steaming hot. This could cause miscarriage, listeria. And then it says avoid large fish such as shark, swordfish, and mackerel due to high levels of mercury. There's a safety check box on page 164 that talks about that. I mean, I think you're going to see or hear a pregnant woman say, honey, you know, I'm really craving a shark right now. Could you run out and get me one? You know what I'm saying? But that's something they need to avoid. They have weird cravings, but I don't know about that. So then some other factors influencing nutrition is your cultural, your ethnic, and religious influences. So for many cultures and religions, foods have like a symbolic or special meaning. You know, there's nothing wrong with this as long as they're getting adequate nutrition. It may be such a thing as they cannot afford nutritious foods. You know, we got to look at that too. They need to get them in touch with some resources like WIC or different programs that can help them get those nutritious foods that they need for pregnancy and for the babies when they come. So page 168 talks about anorexia and bulimia. So some people have an intense fear of becoming obese. And that doesn't change in pregnancy. And page 166 talks about vegetarians should consume consume B12 fortified foods such as soy milk or take a B12 supplement to avoid anemias and neurodevelopmental delays. And talk about adolescents when they're pregnant, they aren't exactly the healthiest eaters in the world, right? So if you've got an adolescent pregnancy, you really need to teach them how to eat healthy. And then pica is a consumption of non-nutritive substances or food. So clay, dirt, cornstarch. A lot of people eat a lot of ice when they're pregnant. And that also has been known to be a sign of anemia when you're eating a lot of ice. A lot of times this is seen with deficiencies in your iron. So iron deficiency anemia is a common complication. Deficiencies in calcium, zinc, thiamine, niacin, vitamin C and D. So it's important with someone with pica to look at the underlying, is there some vitamin deficiencies there? Or maybe socioeconomic status, or maybe mental illness, We've got to look at the whole picture. Conditions such as preeclampsia warrant an increase in protein due to losses through proteinuria. Diabetes mellitus. This is chapter 9, 232 to 242. Pregnant women with diabetes will need to be educated further on nutritional need changes, and we need to let them know that insulin requirements will increase as the pregnancy progresses. The insulin requirements will increase. So pre-existing diabetes mellitus is insufficiency or lack of insulin production and secretion by the pancreas. So some predisposing factors could include family history, obesity, stress, pancreatic tumors. And it may worsen during the second and third trimester because placental hormones are antagonistic to insulin, resulting in insulin resistance. So insulin needs usually decrease in the first trimester and double or quadruple by the end of pregnancy. So women who have been well-controlled diabetics for years may find themselves working harder to maintain normal glucose levels. And some women will develop type 2 diabetes later in life if they have gestational diabetes. So let's look at some of our risk factors. So we're going to call it GDM, gestational diabetes. It's an impairment in carbohydrate metabolism that first manifests during pregnancy. So it happens in 4 to 7% of pregnancies. It's increasing in the U.S. because we're obese. Page 238 has risk factors for developing GDM, such as obesity, polycystic ovary disease, history of diabetes, family history, ethnicity, history of stillbirth, and miscarriage.
Can you say that page number again?
Page 238 is your risk factors. We're going to assess for vascular changes. So they need, frequent eye exams, retinal exams. You might need to do 24-hour urines. Check their thyroid function. Watch them for preeclampsia and eclampsia. Puts them at a higher risk. They have also high risk for having enlarged for gestational age, LGA, or macrosomia, macrosomic infant. That means large infant. We talked about hydramnios, too much fluid. You'll see that with GDM. Increase the volume of amniotic fluid. And remember too, if your moms have had extremely high blood sugars and then your infant's born, and he doesn't have all that good sugar, what's going to happen? His blood sugar is going to drop, so he's going to have issues maintaining his glucose levels. So testing, all pregnant women should be tested for increased glucose levels, especially essential for obesity, excessive hunger and thirst, polyuria, if they have recurrent yeast infection or family history or history of LGA. Some women can go through a pregnancy and not know they have gestational diabetes. Well, then the next pregnancy, it shows up even worse. So if they have a history of a large infant or a lot of fluid, you might want to test them a little quicker. For a diagnostic in lab, so an oral glucose tolerance test is usually done between 24 and 28 weeks of pregnancy. This is page 238, tells you your normal values. And the values are done at 1, 2, and 3 hours. So if 2 or more values are abnormal, then the test confirms diabetes. So if there's a history of diabetes or has high risk factors, then the test may be done earlier. And if at that time it's not diagnosed, then it would be repeated at the 24 to 28 week time frame. No caffeine or smoking 12 hours prior to the test. So then if our women are diagnosed, this is page 242, has a safety box for hypo and hyperglycemia. We should know the symptoms of hypo and hyperglycemia. You learned that in adult 1, right? So if you don't remember, you might want to review those. So we're going to provide education. They're probably going to need a nutritionist or a diabetes educator to help them manage, even though they've done well before, they were diabetic before. Or this may be a new thing for them. So we're going to need that extra education. So diet, insulin, close surveillance. Encourage them to maybe exercise after meals. Make sure they've eaten something. Always carry some hard candy. Wear an ID bracelet. It shows that they're gestational diabetic. Of course, we're going to have to teach them about insulin, how to inject insulin, teach them the signs and symptoms of problems. Ongoing fetal surveillance is of utmost importance. Our viability, our gestational age, the cardiac, the CNS, the fetal growth, the fluid status, all those things can be affected. We have to monitor them closely, so this would be considered a high-risk pregnancy. We talked about the non-stress test, the biophysical profile, to assess for fetal well-being. We may have the weekly non-stress test later in the pregnancy to monitor fetal status. We're going to have to do some good documentation on this. We're educating them about their glucose levels and everything we need to be doing. You gotta cover your butt, right? Okay. So now, hyperemesis gravidarum, or HG. And this will spill over to the next section of fluid and electrolyte because this affects fluid and electrolyte. So it's one of the processes that can affect nutritional status, sometimes quite severely. The importance lies in maintaining proper nutrition and fluid and electrolyte balance. So if severity requires admission to the hospital, you're going to see NPO maybe for the first 24 to 48 hours because they're vomiting up everything they're intaking. IV fluids, electrolytes, and vitamins. We talked about in our SIMS possibly replacement with TPN. We've talked about some of this stuff. Establish a quiet atmosphere. Why is that? Stress and stimuli can make it worse, right? So we're going to decrease the emotional stimuli. So after improvement, they're going to start with small amounts of clear liquids every 1 to 2 hours. And then we're going to increase our foods to regular 6 small meals. You don't want them to overload their stomach, so you're just going to do 6 small meals. If vomiting reoccurs, then we go back to NPO and we start over again, right? Any questions so far? Okay, so fluid needs. So remember, when we talked about maternal adaptations to pregnancy, there's an increase in blood volume, requires a pregnant plant to ingest more fluids for the digestion, absorption, excretion, and circulation. The increased water intake is needed for kidney function as well. And then remember, dehydration later in pregnancy can cause preterm labor. So we can avoid preterm labor by just keeping our clients hydrated. We're a step ahead here. So in our fluid requirements, the normal average person is 8 8-ounce glasses of fluid per day. But our gravid female, we want them to take in about 10 8-ounce glasses of fluid per day. In extreme heat, they may need more due to loss. So at least 4 to 6 of those servings should be water. Of course, alcohol should be avoided because there's no safe amount. I've not determined a safe amount of alcohol during pregnancy. And then caffeine is a stimulant, and it can increase heart rate, blood pressure, and cause more heartburn. So we should probably avoid caffeine. We deal with our hyperemesis gravidarum, chapter 10, page 214. So persistent severe vomiting in our ketones is a measure of acute starvation and weight loss. So ketones in the urine. It is normal for women to experience nausea and vomiting during pregnancy to some extent. That's morning sickness, right? But that usually subsides roughly by about 16 weeks gestation. So a weight loss of 5% or more of total body weight, remember, large ketones equal carbohydrate starvation. So hyperemesis gravidarum, you might see large ketones if they have carbohydrate starvation and severe dehydration. They can have acidosis, hypokalemia. Remember the electrolyte imbalances that this affects. And they say it's possibly caused by increase in HCG, estrogen, or psychological factors. Sometimes it just happens. We don't know the cause. We just treat the symptoms and try to keep our patients as healthy as possible. So in your nursing care, fluid deficit is going to be a big thing. It's an increased risk with nausea and vomiting. So we're going to assess our skin turgor, our ino, our mucous membranes. We'll look at specific gravity of our urine. That's how concentrated it is, right? Temperature, vital signs. We're going to ask our clients, are there certain odors or other factors that attribute to your nausea and vomiting? Does the smell of something make you sick? And then our interventions are going to eat small, frequent meals, maybe some dry, bland foods, nothing spicy, nothing too heavy. Avoid drinking fluids while eating to avoid overfilling of the stomach. Don't drink a big glass of water with your meal. High protein meals. Of course, if we're only going to get small little meals and snacks, they should be high in protein. Spicy foods, we said, should be avoided. Crackers maybe before rising from bed. Decrease in stimuli, could be stress related. Remember, these are interventions for mild symptoms. We'll evaluate them to see what interventions have been effective. Is our plans working? Some diagnostics and labs for HG, CBC. You might see an increase in WBCs, RBCs. Your blood concentration affects those. Of course, our CMP, our complete metabolic profile, to check our electrolytes. We talked about vomiting severe, they're losing potassium, they're screwing everything up with their electrolytes, their cells are shrinking. We look at our UA, our bacteria-specific gravity, or large ketones, because large ketones equals severe dehydration. Some of our management, we talked about APO for 24 to 48 hours. Foods will be introduced slowly. They may give them promethazine, IM, oral, topical, or rectal, Zofran, aldosterone hydrochloride, that's Zofran. Some alternative therapies, there may be foods, jello, crackers, ginger ale, herbs, ginger pills, ginger lollipops, pressure points. You know, there's those C-band bracelets that put a little pressure on certain points on your wrist. Those are supposed to help with nausea. We talked about increasing our amounts of liquid every 1 to 2 hours through regular 6 small meals. We'll go back to NPO if they keep vomiting. Worst case scenario, they might need the TPN. You don't really see a lot of fluid excess, but it can be with increased, with hypertension and preeclampsia. So we're going to assess the degree of edema. Do they have any rapid weight gain? What's their blood pressure looking like? Remember, edema is common and usually benign in later pregnancy, especially when they're on their feet or sitting. It happens. And the physiologic edema is reduced by the client laying in the left lateral decubitus position, elevating the lower extremities. So if they're having swelling in their feet, we'll have them lay on their side and raise their feet up. They could even use compression stockings, you know, the TED hose if they felt like it. Hypertension and then proteinuria with the hypertension is going to indicate preeclampsia. When they're starting to spill that protein in their urine, then we worry about preeclampsia. And we'll talk more about that later. So they may have unilateral leg edema, redness, warmth, and tenderness, of course, makes us think of a DVT. So we want to monitor for that. So unlike your med-surg clients, pregnancy excess is not treated with diuretics. We don't give them Lasix to take the fluid off, you know, until after pregnancy, and even sometimes not then. So we don't get so excited about it. We don't give IV push Lasix, you know. So as I said before, good assessment skills can determine if the symptoms are normal physiologic changes, or is there some kind of disease process present that we need to investigate further. We're talking about hiring, we're talking about psychosocial, different aspects. Like, what does a family mean? What does that mean to people? You know, they may consist of 2 or more members who self-identify as a family, that interact and depend on one another socially, emotionally, and financially. You know, there's different types of families. There's nuclear families, there's extended families, there's single parent families, homosexual families, married blended families, cohabitation family, or no parent family. Maybe there's only grandparents in the home. The no parent family is becoming larger with increased incidences of grandparents raising children. So what does pregnancy do to the family environment? So role transitions are changing from one pattern of behavior and self-image to another. They're becoming parents. Maybe this is their first child. You know, is this a crisis for them? Is it a strain or stressor on the family? Can they afford to have a baby? You know, just listening to our clients can be great help for them and their families. So for many women, pregnancy is a time of turmoil that affects their ability to deal with stress and cope with the changes that will take place over many months. The hormones and things going on with their body. So these changes affect not only the woman, but her partner and other family members as well. Pregnancy and childbearing constitute major developmental phases. And these events are often accompanied by ambivalence and conflicting emotions. Can I do this? I'm not sure. I'm nervous. I'm scared. So So as nurses, we have to have a basic understanding of how a woman's progression through the developmental phases and accompanying emotions affect her and her family's acceptance of this newborn, of this pregnancy and then the newborn. We're going to respect their personal and family values. They're going through a lot. Some situations to discuss. The nurse needs to focus on the functioning of the family and the roles assumed by each family member to promote family function. Keep in mind religious preferences and cultural beliefs. And we avoid imposing personal beliefs and values on the clients and their families. You may help them in finding an appropriate spiritual advisor or clergy. Get in touch with people that can help them become aware of cultural orientation, family communication styles, the structure of their family, their health beliefs, power distribution. Sometimes you have a matriarchal family, sometimes you have a patriarchal family. Who's in charge, you know? Encourage cultural religious practices unless detrimental to their safety. Never assume just because they're of a certain race that they have the same cultural belief. So within every culture, the individual still has their own belief systems. Don't forget that. And you got the siblings too. They have to accept that maybe they're the only child, and now they're going to have to share mom and dad's attention and grandma's attention. Some other things we talk about with our clients when we're doing prenatal visits is we talk about prenatal education. So it's a good way for families to share information and make informed decisions. I have page 149 here on this slide. So there's different types of childbirth education, like the laws and things like that. I'm not going to go into those, but we need to know how much our clients know. We need to assess what do they know, what do we need to teach them, right? We need to know their education level of the process that's going on before we can develop a plan of what we need to teach them. And there's just, like I said, different childbirth methods. So we're going to rest and exercise.
So you said we don't need any other different types like broadly and large, like in depth.
No,
Thank you.
I don't want you to know it all that in depth. Okay. So some things that happen in the first trimester that you might see. Increased salivation. The reason we talk about these common discomforts is if our clients and their family members are aware of what's normal, they won't get so freaked out, right? Oh my God, she's got a nosebleed, or she's tired all the time, or her breasts hurt, or she's peeing all the time. You know, they think that's a problem. But if we teach them what's normal and what to report as problems, then it's going to make it a little easier, right? So page 137, 138 has a list of common discomforts. From fatigue, urinary frequency, breast tenderness, increased salivation, increased vaginal discharge. In your second trimester, heartburn, because you got the relaxation of that cardiac sphincter, slowed peristalsis, delayed gastric emptying, dyspnea because the uterus is expanding upward. We're going to teach them to maintain posture and stretch their arms above their head. Sometimes that'll help them breathe better if they put their arms above their head. It stretches that out a little bit. Leg cramps and varicose veins are going to be due to increased blood supply and weight gain. They're going to have backache. Teach them to stretch their muscles. We talked about lordosis or sway back. And then there's a relaxation of the cartilage and the joints. And where everything's lax and chill. Do they have some dependent ankle edema? They may have that sitting or standing for long periods. So basically, teach them what's normal and what's a sign of complication. Of course, our role is assessment, education, reassurance, rule out disease. Is it normal urinary problems, or do they have UTI? Things like that. And we're still gonna focus too on their health promotion. It's important for them to keep their regularly scheduled appointments with eye doctors, dental exams. Refer them to community services like WIC, we talked about that. Include their families in their decisions. We want to decrease the drama, right? There's a lot of drama usually. Right now with COVID, there's not a lot of family members in the birthing rooms, and so I think it's probably made it a little less Jerry Springer kind of, maybe.
Would have been so much nicer.
Huh?
Would have been so much nicer.
Yeah. So it's just usually the mom, the significant other, you know, and so it's not quite as hectic and dramatic, but it is in the sense that there's COVID, you know, there's that COVID. You know. Other than that, so keep all the regular appointments, because remember, with all that tissue changes and stuff, you can have changes in your eyes, your gums can have hyperplasia, you need good oral hygiene. They need to maintain good relationships, use proper body mechanics, you know, they don't want to, because if your joints and everything are lax and you're lifting something, you have a greater chance of injuring yourself. So we're hoping pregnant we're not lifting anyway, but, you know, no heavy lifting or straining. Page 141, 142, exercise. So check with provider before starting or continuing an exercise program. Routine exercise is preferred 3 times a week. It needs to be non-weight bearing. You want to avoid aerobic. Remember, we don't want to do the step side to side, up and down, because they have that center of gravity is off. We'll do short intervals. Avoid overexertion, and it's important to stretch prior to. Frequently tired, so they need some rest. They may need to get away from their other kids for a while. Maybe have a long day out there where they take the kids to the church, the little church ladies, and then they do something relaxing, get a pedicure or whatever. Take some time for themselves. Schedule rest periods. Maybe just take a nap. Take your kid to daycare and take a nap, you know, whatever. Rest when they can. Use yoga to relieve stress and aches. You know, call them family for support. You don't have time to be on your own. Hopefully you got some support. Okay, questions so far? Almost everyone. Chapter 10, 256 to 265. So our health promotion. Well, initially it was sex education, safer sex practices, barrier methods. You know, we don't want to get sexually transmitted infections. What's your risk factors are multiple sex partners, IV drug use, exposure to blood and blood products, tattoos. Those are all risk factors for some sort of infection. Yearly health checkups, pap smears to diagnose sexually transmitted infections prior to pregnancy. When we're talking about immunizations, Tdap is one of the things they do. Well, what about vaginal infections? So you got bacterial vaginosis, that's going to be a thin watery discharge. They'll do a wet prep to look for cells. The whiff test is a test for the fishy odor that occurs in bacterial vaginosis. A drop of potassium hydroxide is mixed with some vaginal discharge. A positive test is abnormal and consists of a characteristic fishy odor. So our normal vaginal pH in women of childbearing age is about 4.5. Elevated pH is seen in patients who are experiencing symptoms resulting from infections, such as trichomonas or bacterial vaginosis. First you've got your treatment, flagyl, oral or vaginal cream, and then you've got your candidiasis, thick white curdy discharge, severe itching, dyspareunia, dysuria. Usually diagnosed by signs and symptoms, but confirmed by microscopic exam of the discharge. And that treatment is an intravaginal antifungal or oral antifungal. Sexually transmitted infections. Of course, transmitted by sexual activity and blood, semen, or body fluids are exchanged. All pregnant clients should be screened for hepatitis B, HIV, and common sexually transmitted infections. They can have more than one sexually transmitted infection at a time. Of course, all sexual partners must be evaluated and treated as well. They get reinfected. So symptoms could include an unusual sore, discharge with odor, bleeding between periods, burning with urination. Syphilis causes significant damage to the fetus after the 16th to 18th week of intrauterine life. Readily treated with PCN and erythromycin. If the fetus is treated before the 18th week, fetus is rarely affected. Left untreated, transplacental transmission is likely, cause deafness, cognitive delay, osteochondritis, which is inflammation of the bone, or fetal death. Gonorrhea, readily treated with antibiotics, if left untreated, can ascend after delivery. Transmission to the fetus during vaginal delivery may lead to infection and gonorrheal conjunctivitis. And the baby dies. So. Concomitant treatment is usually recommended, so 2 or more drugs at the same time. Chlamydia. Most are asymptomatic, so they don't seek treatment. Complications, self-inflammatory disease, infertility, ectopic pregnancies, can cause premature rupture of membranes. Treated with anti-infective or PCNs. Transmission to neonate during birth causes chlamydial conjunctivitis or neonatal pneumonia. Trichomonas, common STI, malodorous vaginal discharge, vaginal itching and irritation, dyspareunia. You know what dyspareunia is, right?
Painful intercourse.
Painful intercourse, we had that before in our women's lecture. Group B strep. So group B strep is a normal flora, usually doesn't affect much. But in our pregnant women, you know, they check them for group B strep. They do a swab. And if they're positive when they're in labor, they will put them on IV antibiotics to protect the baby. And we usually like to get about 2 doses in 6 hours apart. Group B strep is tested during the 35th to 37th week of pregnancy. And a vaginal swab is used to test for the presence. The rationale is to check it within 5 weeks of delivery. If a patient is preterm or group B strep is unknown, they come in and we don't know, then we're going to treat them with IV antibiotics anyway, right? At least until they know what the GBS status is. That's page 264. So usually use like ampicillin, 1 gram IV every 6 hours times 2 doses or more if possible. So with your group B strep, sometimes respiratory distress and septic shock is seen in infected neonates. The CDC recommends penicillin based on antibiotics for treatment of women during labor. Warts, condyloma acuminata, vaginal warts, infection caused by HPV, commonly known as genital warts. may affect the cervix, vagina, vulva. If a person has enough of these and they're big enough, it can make delivery difficult. I've seen like one client with these, and they were like everywhere. It was crazy, so. It can affect the delivery of the infant if they're in the vaginal area. So commonly known as genital warts, increased growth noted during pregnancy, thought to be from hormones. Increased tissue growth, here we go. Several ways they can be removed during pregnancy, but usually return, usually come back. May be birth due to slice, C-section may be planned. Effect on the fetus is unknown. Torch infections. T is toxoplasmosis. Remember cat litter. Pregnant women can't change cat litter. It can cause fetal death, toxoplasmosis. L is for other, like Hep B, syphilis, HIV. R is your rubella, German measles. They vaccinate after delivery. Remember, you'll see, like with prenatal records, whether they're rubella immune or non-immune. And that's so that after birth, if they're not immune, they'll give them the rubella vaccine. C is for cytomegalovirus infection, asymptomatic. It can cause microcephaly in neonate and large central nervous system abnormalities. Your H is your herpes simplex, type 2 painful genital lesions. Primary infection during pregnancy is associated with congenital infection and pregnancy loss. Torch infections within your first 12 weeks of gestation are associated with fetal developmental anomalies. And your Hep A and your Hep B. Your A is by fecal oral. Your Hep B is blood passing on fetus is very high. Infants born to women who have Hep B during pregnancy should be given H-big, so it's a Hep B immune globulin within 12 hours of delivery. There's our HIV, this is page 261. Blood test to screen for HIV. You've got your ELISA, it's an enzyme-linked immune assay for diagnosis. And that's confirmed with the Western blot. CD4 is a viral load, it's a count of the virus. This is the level of virus present, so we want this number to be low. If they have HIV, we want this number to be low. If our viral load is higher than 1,000, then the risk of transmission is increased. Precautions include, of course, protected sex, and other reproductive education. Important if HIV positive to continue antivirals during their pregnancy. We want to keep the viral load down. If viral loads are high, client should seriously consider C-section to reduce vertical transmission to the infant. However, this does come with an increased risk of maternal morbidity. When you cut somebody open. Antiretroviral such as AZT or Retrovir is often what they'll be on. Just remember the viral load, that's the number of the virus, so we definitely want that to be lower. Let's take a 5-minute break.
What page was the HIV information?